Hello, everyone. My name is Goutham. I'm one of the third-year general fellows at UT Health Houston. I plan to be an interventional fellow next year. Today I'm talking about hydrodynamic contrast recanalization in CTO interventions in the peripheral space. And what this is, or we shorten it to HDR, is a novel CTO crossing technique that was developed by my mentor, Dr. Salman Arain at UT Houston, and Dr. Mauro Carlino, who some of you may recognize as the inventor of the Carlino technique. And we'll discuss a case today and see how that works. So case presentation, this is an 82-year-old man. He's had a history of coronary disease. He has HFrEF, hypertension, hyperlipidemia. He has prior PAD, and he's actually status post an aorta bifem bypass. And he presents to clinic with Rutherford class 3 right lower extremity claudication. He's already on aspirin and Plavix. He's on a PCSK9 inhibitor. And he's tried some rehab previously, but honestly, he was in his 80s, didn't feel like he wanted to go through rehab. He just wanted to get it done and be pain-free. So we planned him for a diagnostic right lower extremity angiogram. And here are the angiograms. Not shown is the patent aorta bifemoral bypass. He did have a right popliteal artery CTO with bridging collaterals down to the AT, PT, and perineal arteries. So what is HDR? And so HDR is a play on a new technique for primary crossing of CTOs using intraplaque contrast injection. And where this originates from is that it's essentially a new iteration of the Carlino technique, which was described back in around 2008 by Dr. Mauro Carlino. Essentially, it's a contrast-guided star. And so for those that are not familiar, it was developed as a bailout strategy when you're in the subintimal space to try and get back into the true lumen distally. It involved a forceful injection of a large amount of contrast, anywhere from 3 to 5 cc's in the subintimal space. And as you can imagine, that can have some unpredictable consequences. You can have perforation, and then even later on in studies, it was shown that there was high rates of restenosis. And so this, as Dr. Carlino himself, he had mentioned that the HDR is this new and improved version of this technique. And so what is it? It is, like I said, an intraplaque contrast modulation where you take a microcatheter, you place it about 2 to 4 millimeters in the proximal cap, and you gently inject less than about 0.5 cc's of contrast into the body of the CTO. Then you take a polymer jacketed wire with a low to medium tip load, and for us, we like to use a lot of the 0.014 systems in the coronary sphere. So, example, a Fielder XT or a Gladius Mongo. And I have an animation here kind of showing how that works, where you see the cap puncture in the proximal cap of the CTO, and then a gentle injection of a small amount of contrast. And the proposed mechanism of action here is that you're recruiting soft, lipid-rich areas of the CTO so that you can have a polymer-jacketed wire traverse pretty easily through the CTO. I'll have this play one more time, but for the past year and a half, at least in our lab that we've been using this, we've been able to use this in the coronary sphere, the peripheral sphere. We've been able to use it antegrade, retrograde, in ISR, in venous, and some subclavian venous interventions as well. And so let me show you this case that this patient came in with. So the intervention, we had a retrograde access. Like I said, he had an aorta bifem bypass before, had a hostile groin, and he didn't have a great DP. So we used the right PT artery with a 5/6 French glide sheet, slender, and you can see the first diagnostic image here, essentially seeing the popliteal CTO there. And then once we got access and we traversed the microcatheter, you can see that this is the actual HDR technique where you can modify the cap or the body of the CTO with, like I said, a very gentle contrast injection. And then we take a Mongo guide wire, and you can see how easily it traverses to the lumen of the SFA. And so the rest of the procedure went pretty smoothly. You can see that on the left there's a distal tip injection showing that we are true lumen. We proceeded with POBA and cutting balloon angioplasty, and then eventually treated with a 50 by 120 millimeter DCB. This is our final result. Again, excellent results, no dissections, perforations, good distal runoff. And so what are the advantages here? The advantages is that we've been using this for coronary and peripheral sphere for quite a while now. The big selling point is that it is intraluminal throughout the procedure. It's easy to learn with no specialized equipment, especially in the era of more devices and getting more stuff done. But here, like I said, a simple microcatheter and contrast injection. At least anecdotally from our institution, we have had faster procedure times compared to the traditional wire escalation approaches or subintimal approaches. And again, even though we use it as a primary crossing strategy, for any CTO operator, it can be used as an adjunct to the rest of their CTO techniques. The disadvantages and some of the feedback we had gotten is that because you're injecting contrast into the body of the CTO, you do get contrast staining. And a lot of operators have mentioned, oh, it looks like a perforation, I get very nervous. And that's true, and we actually had to do a whole separate stain analysis to describe what the stains look like after performing many of these procedures. And essentially stating that those stains are benign and nothing to be worried about. Long-term studies are ongoing, at least in comparing it to procedural times and how does it compare to, again, the traditional wire-based strategies that we have, and then also the subintimal devices that we have as well. So conclusions, HDR is not just a crossing technique, but almost a change in philosophy where instead of using the guide wire to lead through the body of a CTO, we're using contrast. And again, I've showed you how it worked. And again, we're using it a lot in the coronary sphere with a lot of our CTO PCIs. But honestly, it can be used in any CTO and may be preferable in some instances in more complex lesions with long-term studies ongoing. These are my references. These are my acknowledgments. If you want to see more HDR-related content, you can follow my mentor, Dr. Arain. He posts almost every day about his HDR cases.